Myasthenia gravis is fundamentally a postsynaptic disease, which immediately distinguishes it from Lambert-Eaton and botulism. The immune system generates autoantibodies directed against the nicotinic acetylcholine receptor on the motor end plate membrane. These antibodies attack the postsynaptic side of the neuromuscular junction through two distinct simultaneous mechanisms. The first mechanism is direct receptor blockade. The antibodies physically bind to the acetylcholine receptor and prevent acetylcholine from docking. Even when acetylcholine is released normally from the presynaptic terminal and diffuses across the cleft, it cannot bind its receptor effectively because antibodies are occupying or blocking the binding site. Sodium channels stay closed, end plate depolarization fails, and muscle contraction is impaired. The second mechanism is complement-mediated lysis of the postsynaptic membrane itself. The antibodies activate the complement cascade, which physically destroys and breaks down the architecture of the end plate membrane. The receptor-rich folds of the postsynaptic membrane are dissolved. Receptors are lost not just through blockade but through physical structural destruction of the membrane. The clinical result is fluctuating, fatigable muscle weakness that worsens with repeated use and improves with rest. This worsening with activity pattern is the clinical mirror image of Lambert-Eaton. With repetitive nerve stimulation, myasthenia gravis shows a decremental response. The muscle action potential amplitude progressively decreases, rather than the incremental response seen in Lambert-Eaton. In summary, myasthenia gravis causes postsynaptic neuromuscular junction injury, mainly through two broad mechanisms: loss or inactivation of acetylcholine receptor function and structural disruption of the postsynaptic membrane signaling apparatus, both driven by autoantibodies against acetylcholine receptor, AChR, muscle-specific kinase, MuSK, or related proteins. In AChR-positive disease, antibodies damage the end plate by complement activation, receptor cross-linking with internalization, and direct receptor blockade, whereas MuSK antibodies mainly disrupt the signaling needed to cluster and maintain AChRs on the postsynaptic surface. Myasthenia gravis is an autoimmune disorder of postsynaptic neuromuscular transmission in which antibodies target proteins on the postsynaptic muscle membrane and reduce effective neuromuscular signaling. AChR antibodies reduce available receptors by antigenic modulation, meaning cross-linking and removal of acetylcholine receptors from the muscle membrane, and can also directly block receptor function. Mechanism 2. AChR antibodies also activate complement, causing destruction of the postjunctional membrane. Complement-mediated terminal complex deposition is important enough to be a therapeutic target in generalized myasthenia gravis.